Yes, yes. Sorry about that. The link dropped. So, yeah, we were still on the Coombs test, and then the direct and the indirect, and then the question was whether indirect is for only mothers and then direct is for only babies. And I was saying that usually, with the example I gave, I use the rhesus iso immunization as an example because it's a common thing that we all talk about. Oh, rhesus negative mother and mother views the rhesus positive there as a foreign body, so produces antibodies to go and then harm the baby. Most of the time, the antibodies would even go and then kill the baby. So the test we tend to do for the mothers, we do an indirect Coombs test for them. Okay, so that one we just take it and then we want to see if the mother has made any form of antibodies against any in quotes rhesus positive antigens from the baby. Okay, but it doesn't mean that you can't do a direct Coombs test for adults. In conditions whereby you have an autoimmune hemolytic condition, any autoimmune hemolytic condition, okay, meaning that any condition that ends up breaking the red blood cell, which is is coming from an autoimmune source, you can go ahead and do your direct Coombs test to detect if on that red blood cell. Direct Coombs test means that you are detecting directly on the red blood cell. So you go ahead and do a direct Coombs test to detect if on that red blood cell you have an antigen antibody complex formed on that red blood cell. So you can't say that for adults you can only do indirect. You can go ahead and do a direct Coombs test as well. It depends on the condition you are managing. Okay. Are you okay, please? Evans?
Yeah, yes, sir. Yes, sir. I'm okay, sir.
All right, okay, great. Okay, so let's go to iron deficiency anemia. We know that iron deficiency anemia is one of the commonest, if not the commonest cause of anemia, one of the commonest cause of anemia. And iron deficiency anemia, it usually tends to be more common in females actually because of the fact that the menses and all that. So most of the time when you have a female patient coming to you with anemia, make sure that you've taken a menstrual history. Okay, just you want to know the number of days, you want to know how heavy the flow is, you want to know the number of pad the patient uses, you want to know if the pad is fully soaked. It's not enough to just say, well, how many days do you have your menses for? It's not enough to say that. Okay, just a minute. All right, okay. So it's not enough to say that you need to try and assess if your patient here is actually having a hard time when it comes to bleeding. Because if you just say, well, how many days you bleed for, a patient can tell you 5 days, and we know the normal is 2 to 8 days. So you say, oh, 5 days, then it's fine. I don't think that's the cause of the anemia. But you go in there and then you realize that this 5 days, the patient's flows heavy throughout all these 5 days, can use about 5 parts, and it all gets fully soaked. There and then, if you are taking that history, you would be able to pick the cause for your diagnosis straightforward if you take a detailed history in that sense. Okay. So the body has a limited, ability to absorb iron and all that. To absorb iron effectively, you need vitamin C and all that. Because of this and the fact that people bleed, even males develop hemorrhoids and they bleed, iron deficiency anemia is like the most common cause of anemia. Usually you would have the classic headache, dizziness, palpitation, easy fatigability. And on top of that, the lack of iron also leads to certain other features that once you are able to pick up, it gives you the diagnosis or the cause of the anemia. So people who have iron deficiency anemia would usually have brittle nails. So their nails will break easily. Okay. Then when you take a look at the nails, it looks like a spoon shaped. Okay, so when you go to slide 10, you can see how the nail is looking, a spoon-shaped nail, which we call koilonychia. Okay, it's a common question examiners like asking, so maybe you might say it in your exams. Then they can have angular stomatitis. Stomatitis means inflammation of the mouth. And if this inflammation is happening at the angles of the mouth, we call it angular stomatitis. Their hair can also be brittle. It breaks easily. When they pull out their tongue looks very, very atrophic. Okay. And then they can develop a certain syndrome, which we call Plummer-Vinson or Patterson-Brown-Kelly syndrome. Okay, it's just a combination of iron deficiency anemia, difficulty in swallowing, and then inflammation of the tongue. So a patient who comes to with iron deficiency anemia, swollen tongue, which we call glossitis, and then difficulty in swallowing, we say the person has Plummer-Vinson syndrome or Patterson-Brown-Kelly syndrome. So you take a look at the picture, you see how it looks. Okay. Investigation. So we need to do a full blood count, HB, to help us even make the diagnosis that this patient's HB is low or this patient is anemic. That's the first thing. And then you remember I said that your full blood count is very, very, very essential that we do a full blood count because we want to see other parameters as well. So MCV, MCH, all those things would help you make a diagnosis of what you are dealing with. So I'm trying to, okay. Just a minute, please. So Nick, kindly check your WhatsApp and then you can forward to the page. I've sent you 2 pictures of lab copies. Okay. So you can put it on the page and then we discuss.
All right.
Yeah. So usually you do your full blood counts, you see your HB, and then you also take a look at your MCV and your MCH clearly. We are saying that MCV stands for mean cell volume, and then MCH is mean cell hemoglobin. Okay, so MCV, volume, it tells you something. It tells you about the size of the cell. And then MCH, hemoglobin, it tells you about the content of the cell in terms of the level of the hemoglobin. Okay, so usually we expect that your MCV, when you do your full blood count, they give you a reference range. Some people will tell you 80 to 90 and all that. Okay, femtoliters. But always pay attention to the reference range. Your MCH would usually be in picograms. So always pay attention to the reference range. What we know is that in iron deficiency anemia, usually your MCV will be reduced and your MCH will be reduced. What does this mean? It means that we are saying MCV tells us the size of the cell. So if your MCV is high, you have a patient whose MCV is around 100, and it means the red blood cell is big. Also, if the MCV is lower than your reference range, like MCV of about 70 or 68, it means your red blood cell is small than normal. Okay, if you have an MCH which is also low, then it means that the patient is lacking HB. So the redness of the red blood cell is not there. It tells you that the red blood cell is faded. So MCH, which tells you the hemoglobin status there, mean cell hemoglobin, once it's low, then it tells you that your cell over there is faded. And then in medical terms, we call that hypochromic. Chromic is for color. So hypochromic. Okay. If you have a cell which is very, very red, then we say the cell is hyperchromic. Okay. If you have a cell which is very small because the MCV is low, then we say the cell is microcytic. If the cell is big because MCV is big, then we say the cell is macrocytic. Okay. So if you look at the picture I put on the page, you can see the copy here. So it gives you the HB of 11. Okay, so that's more of borderline. But when you take a look at the reference range there is 12 to 15. So it's like this is a female patient. Okay, can we all see the HB? So 11, and then yes, and then the reference range is 12 to 15. Okay, So that tells you that, all right, okay, this is a female patient who is anemic. Then we come and then we look at MCV. Okay, the MCV there, the MCV we have here is 108. But you look at the reference range, it's like 80 to 94. So it means the MCV is high. Okay. So clearly this tells us that this patient's red blood cell is what? Is big. And as we go on, you realize that some type of anemia will give you a big red blood cell. Some type of anemia will give you a small red blood cell with a faded color. Okay. So back to iron deficiency anemia, you realize that let me see. All right, okay. So when you take a look at iron deficiency anemia, we are saying that a patient who has iron deficiency anemia, when you do your full blood count, MCV will be small, MCH will be small. So they will have small red blood cells, and then they'll have faded red blood cells. And in medical term, we say that they have microcytic hypochromic anemia. So whenever you hear anybody say microcytic hypochromic anemia, the first thing that you should be thinking about is, oh, this is clearly iron deficiency anemia. Red blood cell is small and it is faded as well. Okay. And your blood film for iron deficiency anemia, apart from the microcytic hypochromic nature of your red blood cells, the red blood cells would have varying sizes. You see some of the cells are normal, some are smaller. Once you have varying sizes of red blood cells, we call it anisocytosis. Okay, so varying sizes of red blood cells. And some of the red blood cells will have varying shapes. Varying shapes of red blood cell is called poikilocytosis. Okay, so if you see it in your MCQ, you should know what to choose. So iron deficiency anemia gives you microcytic.
Please, can you go over the names again?
So iron deficiency anemia will give you a red blood cell that is smaller, and then a red blood cell which is what? Faded. So that one we say microcytic, meaning it's small. Hypochromic, meaning it's what? It's faded. And then it gives you red blood cells. You look at the blood film and you realize some of your red blood cells are bigger. Some are very small because of the iron deficiency, but you still have some normal cells somewhere. So they have different sizes. Once you have your blood film has different sizes of red blood cell, we call it anisocytosis. So when you check the slide, you see it, anisocytosis. And then when you have a blood film which has different shapes, you call it poikilocytosis. Go to slide 12. When you go to slide 12, you can see a normal blood smear. You see how all the cells are looking the same, like they are all in the same age group and all that. And look at the microcytic hypochromic. Some of the cells look bigger than the others. You see some of them too, they look whiter than the others. So then we say that, okay, this patient has microcytic hypochromic. At the same time, because of the fact that some are bigger than the others, we say the patient has anisocytosis. And you can see that some of the cells, you can see one cell looking like some bentua over there, some look like eggs and all that. So, yes, please.
And what is the shape of the poikilocyte?
So that's what I'm saying. So once you have, so the poikilocyte means you have abnormal shape. So it's not just a term for one cell.
Okay.
If we say poikilocytosis, meaning that the blood film doesn't have a uniform shape. They are varying shapes. So you can see some look like an egg. You can have one that looks like the bentua looks like, it's called a teardrop cell. You can have a teardrop there. And then the one that looks like the egg, you see how it looks like an ellipse, so elliptocytes, you see. So once you have one blood film, but this blood film has round red blood cell, has an elliptocyte, has a teardrop cell, then we say that there's what? Poikilocytosis. You understand?
Yes, sir.
Yes. So let's go on.
And that is a deficiency of iron deficiency.
Yes. A description of iron deficiency anemia, usually. Yeah. And then I said that iron deficiency anemia, apart from your HB, we do what we call iron studies. And you should also know the parameters of iron studies, because I'll ask you in your exams. And I mean, once you start practicing, you have to understand parameters of iron studies. So iron studies, we look at the first parameter is like the total, the total iron. So once you are doing iron studies, you want to know if the iron is high or low. So we do iron studies for two things. If you have iron deficiency anemia, we'll do iron studies. If we are thinking you have iron deficiency anemia, we'll do iron studies because we want to know the level of iron you have. If we are thinking you have a condition whereby you are unable to break down iron, so you have an increased level of iron, okay, a condition called hemochromatosis, we'll do what? Iron studies as well, because we want to know the level of the iron. So the first parameter is the total iron. Yes, please. You have a question? Yes, please. If you have a question, you can let it come. Otherwise, we'll go on and we'll wait for your question. So your total iron. Okay, so your total iron in iron deficiency anemia, your total iron will be reduced, and that is self-explanatory because once you are deficient, iron level will be reduced. Okay, so there's fall in serum iron. Then the next parameter is what we call TIBC, or total iron binding capacity. Okay, so when you check slide 11, you would see TIBC, or total iron binding capacity. When your iron levels fall, okay, let's say you're a rich man and then something happens and you're losing all your money. What will you do to the smallest amount of money that you got left? You're a rich man, you are buying Mercedes, you are buying houses and all that. You are just spending lavishly. And now you realize that actually my money is getting finished. The smallest amount of money you have, what will you do? You try and hold on tight to it, right? So that's how iron is. Once your iron level starts falling, your body naturally goes into a compensatory mode. So your body starts holding on to iron. And that's what total iron binding capacity is. So someone will say, oh, why is it that the patient has iron deficiency and we are saying total iron binding capacity will be increased? It's because we want the patient to hold on to the rest of the iron left. So bind the iron strongly. So there will be increased total iron binding capacity when you have iron deficiency anemia. This thing usually confuses clinicians, but don't get confused. If you have a lot and all of a sudden you are losing, the smallest you have, you hold binding capacity. Okay. Serum ferritin, iron is stored as ferritin. So like excess iron is stored as ferritin. So if you have iron deficiency, we will go into your iron stores and go and use what is there. So your ferritin will be what? Will be low. And then once you have iron deficiency, it means the iron getting to your various parts of your body will be reduced. Iron is usually carried by a trotron in the blood called transferrin. Okay, so when your body realizes that iron is not getting to this part, your body starts making a lot of this transferrin, hoping that maybe you don't have enough transferrin. That's why you are not transporting the iron. So your body makes lots of transferrin as a compensation. Okay, so transferrin levels would increase. So when you are looking at iron studies in iron deficiency anemia, one, there will be fall of the serum iron will fall, the total iron binding capacity would increase, your serum ferritin level, which is the store of your ions, will be depleted. We'll go there and go and take it because Charlie, you don't have money. So you break the bank, go to your bank and go and take the rest of the money you have there. So your serum ferritin will fall. And then your body will start making lots of transferrin to transfer the ions. Okay, so there'll be increased transferrin receptor studies in iron deficiency anemia. So when you read, please pay close attention to it.
Hello, sir.
Different? Yes, please.
Hello, sir. Please, are you saying the iron study is also a different test after you realize that patient is anemic?
Yes. So after you realize the patient is anemic and you want to make a diagnosis, as I said, anemia is just a name given to a collection of symptoms. Anemia is not a diagnosis. And people even say anemia is a symptom, but of course it's a diagnosis because it's made up of lots of symptoms, but it is not in a complete diagnosis. You can't just say patient has anemia and you stop there. It doesn't speak, we won't speak well of you as a clinician. Patient has anemia. So what do I do? You need to know the type of anemia because that's what direct you to how you manage the patient. Classic example, you have a patient who has chronic kidney disease, comes to you, and HB, this patient's HB is 9. Okay. But because you failed to take a very good history, you didn't even pick up the chronic kidney disease, or the patient mentioned the chronic kidney disease, but you didn't even investigate it. So you're not even thinking. You're like, oh, okay, HB is low. Let me give the patient iron. Let me give the patient bioferron. And usually that's what we do. But then you do this and then you realize that you have made a mistake, because in a patient with kidney disease, if you are giving the patient iron, the iron won't do anything, because the patient's problem is not the iron. The patient has enough iron, but the patient doesn't have erythropoietin to combine the iron to make HB. So if you don't know the diagnosis or the secondary aspect of your anemia, you go and give iron, but your patient will still be anemic, because you haven't solved the patient's problem. So when it comes to iron deficiency anemia, once the HB is low, one of the investigations we do to confirm that we have iron deficiency anemia is to do iron studies. And the iron studies is what will direct us and say, indeed, total serum iron is reduced, total iron binding capacity is increased, serum transferrin is increased, and then ferritin is reduced. So clearly this patient lacks iron. So this is iron deficiency anemia. Okay.
Thank you very much. But sir, in case you get a copy of the ions, then you put it on the platform for us to see. If it's
all right,
possible.
okay.
Thank you
I'll
very
do
much,
that.
sir.
You're welcome. You're welcome.
Yes,
please. Yes.
So sometimes a clinician can ask for full blood count, and the patient's HB will be low.
Yes.
And with the full blood count, they will add other tests like maybe as 4.1 or 4 point, like within that range, 4.5 to 4 point. And you present the results, because you the lab technician might think it's an agency. So you send the HB result to the clinician for maybe a referral or like a transfusion. And they will still have to wait. They will tell you we are waiting for the BFN. So I want to know at which level of HB do you need to transfuse the patient? Or if the patient maybe is having a malaria, which is leading to the low HB, do you have to treat the malaria and leave the transfusion? Because it's something that always bothers me. Yes.
Okay. So once you take your seat there and you are calling the shots, whenever you have a patient coming to you and the HB is less than 7, you have to start considering transfusion. Especially if the HB is less than 7 and the patient has symptoms. Patient is symptomatic, dizziness, palpitations, you have to consider transfusion. The only times that we sometimes will relax a bit if the HB is less than 7 is what I told you about. If you have a patient who has sickle cell, maybe the patient's steady state HB is between 6 and 7. So already this patient coming to you has been living with an HB of 6 and 7 for like years. So when you do something like that, and then you see HB of maybe 6.8, you're not in a hurry to go and transfuse the patient, because transfusion also comes with risks. You're not in a hurry to go and transfuse the patient because you know that this is the patient's steady state HB. But even that, if your patient comes sickle cell and HB is less than 7, and you're thinking maybe steady state HB is 6.5, but as part of your history, you pick up that the patient is hemolyzing, or the patient's red blood cell is hemolyzing. This HB, which is 6.5, in less than 24 hours, the HB will drop to like 5, because the patient is still breaking down red blood cells. So you have to, once the HB is less than 7, you have to start making plans for a possible transfusion. You understand? So that is it over there. And I know that, yes, I get you. Sometimes they'll tell you they are waiting for BF. The reason why they do that is before they refer, they don't want to just refer and say low HB, goes to the other facility, and now they are making it difficult for them, and now they also have to go and test for wait for BF result, and then it will delay. So once they are running, and full blood count is faster to run than your BF. Once you are running, they are hoping that by the time the full blood count comes in, it shouldn't take more than 30 minutes to have your BF result also coming in. And that's why sometimes they decide to wait a bit. But me as a clinician, if I'm in a facility where transfusion is possible, and then I have a patient who is coming with fever and all that, and I've been able to pick up hemolysis. So I've requested for malaria. The malaria there is just to help me decide if I should go ahead and give anti-malarials or not. Because the malaria test can come and it's negative. Doesn't mean I'll transfuse my patient. So that one is not going to stand in my way of saying, no, I'm waiting for BF before I transfuse the patient. The transfusion wouldn't have an effect on the malaria, but the malaria test there is telling you that after you transfuse, if you still haven't treated the illness or the sickness, then the blood that you've transfused will also break down again. So it's like you've done cost 90. So you're preparing to transfuse, and at the same time, you want to know why the patient's red blood cells are breaking down and why the HB is low. So you need the other lab as well, but that shouldn't stop you from doing what is emergent. At that point, the transfusion or trying to raise the HB is more of an emergency to you than deciding to give the anti-malarials, because it can come and it's negative, but rather the patient has some sepsis or something. Worst case scenario is patient comes, HB is low, you know you need to transfuse, and at the same time, the patient has WBC of like 18, and then you tell me you are waiting for BF. It is worst practice. You have to think that the reason why the hemolysis is there is because the patient has sepsis, because clearly WBC is high. High WBC means sepsis, and sepsis can cause hemolysis. So start managing for the sepsis and start transfusing. Your malaria test comes, when it comes and it tells you malaria is positive, then you add it up. Patient has sepsis and also has malaria at the same time. But you don't say you are waiting for your BF before you take a decision. It's wrong. Okay. Yes, please.
In some cases too, the clinician try to treat malaria before they treat say, I don't understand, because I've seen some clinicians trying to give malaria dosage. Then they'll tell you after you finish the malaria dosage, then you start taking, let's say, this black tonic, which I don't really understand. Yes.
Yeah, so it's also not.
But the HB, when I checked, the HB wasn't so much down. It was around 10 point something. That's my first question. And my second question is, why is it that there are some men that their HB mostly is around let's say 14, but when it drops, let's say to 10, they start feeling palpitations.
All right. Okay.
Why is it like that?
Okay. So yeah, so that's a good one.
Sir, before this one, actually not clear with my question. So does it mean like HB as low as
is it Odima again?
4 point something? Would the patient go to coma or something, can fall out? Because I've been having that kind of encounter mostly. A patient's HB will be as low as 4 point something, and the clinician is waiting for your BF, which will take more than 45 to 1 hour minute.
Yes. So I agree. That's what I'm saying, that's a wrong practice, because you can lose the patient. But sometimes if your HB is around 4 point something, you know that your patients can hold on for at least 30 to 45 minutes. At that time that they are waiting, the patient's HB is not going to fall to like 1 point something. We've had people with HB, someone walked into my facility with HB 2.8. So, yes, so it's a warning. HB 4 point something is severe anemia, so prepare to transfuse. But even whilst you are preparing to transfuse, you know that the other thing is maybe your facility doesn't even have a blood bank and all that. So that one requires an issue on its own, and then it might even delay your management. But it doesn't mean if you are delaying the management for about 30 minutes, you are going to lose your patient. I mean, in medicine, things do happen. But the reason why sometimes the clinicians will say, oh, I'm waiting for this is because they are used to seeing cases like that, and they know that, oh, HB 4 point something, my malaria can come before I, go ahead and decide to do something. But for me, as I always say, if you have access to the blood bank and your HB is 4 point something, you don't need the anti-malarials because it doesn't change your management in any ways. Okay. Once it comes, you can always add it up. It's part of your plan. So you always add it up to your plan. But it doesn't mean that, oh, let me do this. And no, you always add it to your plan.
Thank you, sir.
My question.
Yes. Yes, please. I'm coming. So you wanted to know at what point. So any HB below 7, as I said, you have to consider transfusing the patient. If that is not a patient's steady state HB, okay. There are other people too who are against transfusion and all that, and that one too. There are ways of going around it. Now we can give IV iron, and then we can add erythropoietin to it. Okay, so when we get to management, we'll see that as well. Please, the other question.
Sir, I was asking, there are some clinicians that if the patient is having malaria, he would like to treat the malaria first before telling the patient to start taking the black tonic. I've seen some before over.
So you want to know why we do that?
Yes, and there are some patients that their HB is around, let's say, sometimes 14, sometimes 15. The moment it drops just 1 gram below their normal range, then they start feeling happy. They start having palpitations.
Yeah, good. So we do that because the reason why we tend to do that is the malaria parasites, they feed on iron. So if you diagnose malaria and you want the patient to take the anti-malarial and then the iron at the same time, we feel you're actually going to cause the parasites to overgrow more. It's just like people who have sepsis. If someone has sepsis or extreme bacterial infection, we don't want to give the person iron because the bacteria will feed on the iron. So there will be more proliferation of bacteria. So we rather want to treat the infection, and we'll tell you after you're done with your anti-malarial or your antibiotic, then you start taking the iron medication. That's the reason why we do that. Are you okay with that one?
Yes, sir. Yes, I'm okay. I'm fine.
And then the other aspect is, that's why I keep hitting on steady state HB. Yeah. So you could have a patient whose HB constantly is around 15. Even though we have a standard and we are saying males below 13, you can have a patient who comes to you with HB 13 on the dot. Ideally, another man won't feel dizzy or won't have palpitation, but this patient will come to you with palpitations, dizziness, because the patient constantly is around 16, but now the patient is doing 13. So there's a reason why. You look for the reason why. Maybe now the patient isn't eating well, or the patient is having some form of hemorrhoids. So it's just a beginning of what might happen later if you don't intervene. And that's why this patient, we don't expect that to be feeling dizzy and having palpitation and all at HB 13 will come to you having it, because the patient's usual HB or steady state HB is way higher than 13. So that's the reason why.
Okay, thank you, sir.
You're welcome. You're welcome. Yeah, Chancellor, I'll take your question.
Okay, sir. I want to ask if someone is a diabetic patient, is anemic.
Yeah.
Do we give the normal blood tonic, as we see that the blood tonic
because
is mostly made of sugars?
Because of the sugar. Yeah, so you have to consider that if you are giving a diabetic patient medication, you have to think about all that. So ideally for me, I like going for capsules instead of syrups for them. Even when you have a diabetic who has a cough and you want to give, try thinking about one that isn't so sugary. Sometimes it's just a marginal increase, but for a patient who has a poorly controlled diabetes, this slight sugar you're adding might shoot it up, and then it might make the condition worse. So you need to consider that as well. So you can go capsule instead of liquidy.
Okay. Thank you.
All right. You're welcome.
Hello,
So
sir.
differential, yes, please.
All right. So I want to ask, so the iron studies is done to rule out other causes of anemia?
It's done to help you make a proper diagnosis of iron deficiency anemia.
Okay.
Are you okay?
Yes, sir.
Yep. It's done to help you make a proper diagnosis that, oh, HB is low, and your iron studies clearly show that ferritin levels are depleted, serum iron level is down, total iron binding capacity is high, transferrin is high. Everybody who sees that knows that this patient has a clear iron deficiency anemia. Okay.
Okay, sir.
All right. So your differential diagnosis, yes, it might draw less than that. So your differential diagnosis usually some conditions too can give you small cells with faded cells, just like the iron deficiency anemia, where we say microcytosis and then hypochromasia or hypochromic macrocytic anemia. A condition like thalassemia can give you that. Okay, thalassemia is a condition whereby, the hemoglobin chain in the red blood cell is made up of 2 alpha globulin chains and 2 beta globulin chains. You could sometimes have a medical condition where you have reduced number of globulin chains. So you have someone who doesn't have alpha globulin chains at all, or someone who has only 1 beta globulin chain, all those things. It's called thalassemia. Okay. So thalassemia, they also tend to have symptoms that look like sickle cell. So you have thalassemia. There's also a condition called sideroblastic anemia, where you have a patient who's anemic. You look at the red blood cell, and the red blood cell contains iron granules. It's called sideroblastic anemia. Okay, so all these things, anemia of chronic disease, chronic infection, can sometimes give you small red blood cells, faded red blood cells. Usually, it will give you normocytic normochromic anemia, meaning normal size, normal color, but sometimes you could have macrocytic hypochromic. So how do we manage iron deficiency anemia? So usually we give iron 200 milligrams 3 times daily, okay, for about 3 to 6 months. Thankfully, now we have our bioferrons, we have Totima, there's even IV iron. So that one you give, and then it goes up faster than your usual elementary iron or your oral iron. Your parenteral iron, once you give, after you give, usually you give and you give alternate days. So if you give today, you don't give tomorrow, and you give. You do that for about 3 to 5 times. You check the HB. The HB would come up very nicely for you. Then now you put your patients on oral. Okay, so there are now various ways of managing iron deficiency anemia. You can go for the usual oral. We know. You can go for the new types of oral spiroglobin bioferron on the market. You can go for Totima as well. Then you can go for your IV iron, depending on how low your HB is. The strategy I use is that if I'm seeing a patient who is anemic, but then HB is around